Welcome to part one of this Movement is Life presentation on value in healthcare. Movement is Life is a multidisciplinary coalition seeking to eliminate racial, ethnic, gender, and geographic disparities in muscle and joint health by promoting physical mobility to improve quality of life among African American, Hispanic, Latina women, and women who live in rural communities. Since 2010, Movement is Life has focused on the elimination of musculoskeletal disparities in healthcare. Limited mobility due to joint pain has a dramatic impact on comorbid health conditions, including obesity, type 2 diabetes, and heart disease. The Movement is Life caucus receives financial support from Zimmer Biomet. Movement is Life goals are to raise awareness of the epidemic of limited mobility and develop functional solutions to reduce disparities. Strategize with healthcare providers, community leaders, and other stakeholders to combat disabling joint pain among women, African Americans, and Hispanics. To implement community-based initiatives to combat arthritis and comorbid conditions that lead to immobility. To advocate to decrease musculoskeletal health disparities that contribute to joint pain and immobility, and educate patients on the importance of daily physical activity in decreasing poor joint health and improving overall health. This presentation is driven by the development of the value monograph you see here. This monograph arose from a need to better understand evolving changes in healthcare payment policy. MIL sought to answer the question, is there value in the current healthcare system, and if so, for whom? After 2 years of conceptualizing and debate, a review of the literature, and feedback from patient focus groups, the value monograph was developed and published. The stakeholders who have a vital interest in defining value in healthcare include patients, the providers who serve them, and payers and policymakers who define how providers are paid for their services and care. In general terms, value is often defined as quality divided by cost. Value implies a balance among patient outcomes, the services used to achieve those outcomes, and the cost of those services. When this balance is reached, patients achieve their goals for function and overall health, providers give the most appropriate services efficiently, and the healthcare services provided are cost effective. In our current healthcare system, stakeholder values are not balanced. The cost of healthcare in the United States is not sustainable. Although the United States spends significantly more per person on healthcare than other industrialized nations, our healthcare outcomes are no better and often are worse. Unfortunately, the system is complex, placing the stakeholders at odds. Unfortunately, patients are typically viewed as the lowest priority stakeholders in our healthcare system. Payers and providers are often provided as the more important. That begs the question, where does the patient perspective come into play? Today, most definitions of quality in healthcare include a component of the patient experience, assessed by instruments like the CAHPS or Press Ganey surveys. But what do patients in disadvantaged communities really value in their healthcare encounters? What really matters to them? How do alternative payment systems affect the value patients receive? Finally, how can we as individual providers improve the value of our care to our patients? To better understand what patients value, Movement is Life convened focus groups of women representing communities of color, African American women in Cleveland, Hispanic in Chicago, as well as community health workers in rural Kentucky, to identify the challenges and frustrations they experienced in their interactions with providers and the healthcare system. In all three focus groups, common challenges and sources of frustration during an interaction with the provider included an overall lack of communication or impaired communication, a lack of competence or failure to attend to the patient's needs, a lack of professionalism, a lack of courtesy, and a perception of provider bias. Other common frustrations were healthcare system problems involving electronic health records and financial concerns, including insurance coverage gaps and out-of-pocket costs, failure to recognize or manage common conditions such as depression and the end organ damage caused by diabetes. System challenges may be beyond our control. However, there are multiple ways in which we as providers can enhance the value of our patient interactions. The most common frustration among the participants in all three focus groups was deficient communication, both between clinicians and patients and among providers. Patients felt that the physicians, nurse practitioners, or physician's assistants were more interested in their computer than in looking at or listening to them. For a more in-depth discussion, please see Case Study 1. Providers often fail to address patients' needs and concerns. They fail to engage both the patients as persons and the patient's agenda for their visits. For an in-depth discussion, please see Value Case Study number 2. Many of the focus group members perceived their care as discourteous or disrespectful. They felt that providers were openly biased against them. One perceived bias relates to the current opioid addiction crisis, and the second, more long-standing stereotypic bias is a perceived bias against the Latinx population. For in-depth discussion of the pain medication issue, please see Case Study 3. For in-depth discussion of the second case, please see Case Study 4. Patients consistently identified policies, procedures, and processes of the healthcare system and out-of-pocket costs as frustrations and barriers to receiving care. Although we probably can't control payment policies, we should be aware that such policies can be barriers to our patients' ability to receive care. Providers often fail to identify or manage common conditions such as depression. Many of the patients in the focus groups were diabetic and commented upon failures to manage even the most common morbidities associated with their diabetes. Please see Case Study number 5. Patients not only identified problems but also offered solutions that addressed their needs. Regarding communication, patients desired prompt responses to phone calls and a dialogue between provider and patient. An effective provider-patient dialogue requires respectful treatment and attentive listening. Patients expect respectful, unbiased, non-judgmental care. They expect their dignity as human beings to be acknowledged and protected. Respectful communication is discussed at greater length in Case Study 6. Patients expect and need their care to be timely, prompt, and professional. Patients want and need care that is personalized to their unique needs. Proper care should be tailored to their needs and to the best available evidence, not the patient's insurance status. They want their providers to partner with them and share the decision-making process. Appropriate care should not be driven by insurance type. It should be delivered by a practitioner who is compassionate and willing to partner with the patient. Patients expect their providers to be aware of the cost of the care they recommend. The cost of some prescriptions, for example, may force the patient to choose between buying the prescription, buying groceries, or paying rent. In such instances, non-compliance with recommended care may be unavoidable, but could cause the patient to be lemon-dropped. To summarize, patients want and need timely, cost-conscious professional care. They need care that is respectful and comprehensive. Most of all, they value effective communication with their providers. Patients characterized ideal healthcare as being patient-centered with effective dialogue to ensure interaction, understanding, and shared decision-making with their providers. Respectful, unbiased, non-judgmental care was emphasized by all groups. Most of all, they value respect for their human dignity. So, are healthcare payment models impacting care? In Part 2 of this series, we'll explore the issue and provide a brief overview of payment models for you to consider. For the perspectives of healthcare providers, policymakers, and payers, please go to Value in Healthcare Part 2.